So I will be talking about the alphabet soup of vasculitis medications. I know you have been exposed to these now, and we start rattling off all these letters, and you're on this and that, and I'm going to be talking about, obviously I can't cover every medication used in the treatment of vasculitis, but I'll be highlighting some of the big ones that we use, some of the side effects, some of the things to look out for, and of course at the end I'll take any questions, and especially focusing on the updates over the last couple of years. And there have been some, and it's actually been very exciting this last bunch of years in terms of the increased information about what we can target in vasculitides, and then also ways that we can really try to limit steroids, which is both yours and our least favorite friend. So with that, these are the objectives of the talk, and I can't say anything there, so I'll just be glancing back here once in a while. So these are some of the main medications that I will be discussing. The oral medications up here are Methotrexate, Azathioprine, and Avocopan. And the subcutaneous or infusion medications are going to be Tocilizumab, Mepolizumab, Rituximab, and Cyclophosphamide. So, all right, we'll get started here. I always think about things in terms of a case, and so we'll start with the case. So this is a 55-year-old male. He presents to the ER with fevers, trouble breathing. He's coughing up blood. He has leg swelling. We get some blood work. There's some anemia, so low hemoglobin, elevated creatinine, so worsened kidney function. The urine has 4 grams of protein as well as blood. In this patient, the C-ANCA is positive with a positive PR3. There's no signs of any infection. He has a CT chest that shows nodular lesions, and a kidney biopsy is performed and shows vasculitis in the kidneys. So the diagnosis in this case is granulomatosis with polyangiitis. And what is our goal in all of these diseases, not just GPA, but in vasculitis in general? Our goal is really to first control the inflammation, so try to shut everything down, and then of course try to prevent relapses. And so I try to split it up, regardless of the vasculitis I'm treating, in terms of induction and maintenance. So when I think about vasculitis, itis is inflammation, right? So I think of it as like your blood vessels are on fire. And what can we use to put out that fire as quickly and efficiently as possible, trying to avoid damage from accruing? And some of the main medications that we use in induction for GPA and some of our other diseases, which we'll talk about, include cyclophosphamide, Rituximab. We use Methotrexate in some limited disease for GPA and Avocopan. And then the second phase of disease is maintenance. So that's really trying to prevent relapses. And this is a delicate balance in a lot of patients. So we're trying to keep out this fire, right? We want to keep that inflammation down, but we don't want to cause a flood by just throwing so much immunosuppressive at you that you're just suffering from infections and side effects from medication without actually needing necessarily that much. And it's not always super clear what that perfect amount is, and it's not always the same for every person. So what are medicines that we use in maintenance? Rituximab, Azathioprine, occasionally we'll use mycophenolate mofetil or Methotrexate. All right, so I'm starting kind of way back. We have, like I said, come a really long way. Initially, we only had steroids to treat vasculitis. That was what we were using consistently. And then cyclophosphamide was introduced. That was one of our first original agents used for managing vasculitis, and is still used in some cases today in ANCA vasculitis. And it really transformed the disease from a fatal one to something that was chronic and relapsing. So it was very effective at shutting down the inflammation. 93% of people could achieve remission, but 50% of people had significant side effects, and they weren't trivial. They include cystitis, infertility, malignancies, bladder cancer, infections. And beyond the fact that they had that we were suffering from all these side effects, relapses were also still very common. So relapses were about 50% in the first 5 years. And we know that every time there's a relapse, there's more inflammation, more damage, more medications. So what can we use to try to break that cycle? So cyclophosphamide, it was initially used as a part of chemotherapeutic regimens, but it was found to be effective in some rheumatic diseases. So we use it in a lot of organ and life-threatening vasculitis. Again, we're always trying to adjust our aggressiveness of medication to the aggressiveness of the inflammation in your body and what organs are involved, and that's how we sort of think about severe or mild to moderate disease. Mild to moderate doesn't mean it doesn't affect your lifestyle or it doesn't impact you. It just means that we're trying to figure out how aggressive we need to be and how intense with the medication regimen. So cyclophosphamide is also used in polyarteritis nodosa, cryoglobulonemic vasculitis, and Takayasu's arteritis. And really a lot of the toxicities with cyclophosphamide are based on the cumulative dose. So longer term exposure, repeat exposures are going to increase the toxicities. It used to be that that was the only medicine we could use to induce remission, and that was also the only medicine we could use to keep people in remission. So people were on this drug for a very long time, so toxicities were very common. But now we really only use it for the first 3 to 6 months and then switch over to a different maintenance agent. I'm not going to read this. It's a very busy slide. I just wanted it here for people to have as references if you go back to review some of the information. But like I mentioned, some of the toxicities for Cytoxan include bone marrow suppression, gonadal toxicity, infectious risks, and you can just see more detailed information in the column on things to note, but I won't read through all that. And then other things include hemorrhagic cystitis or bladder cancer, and malignancy. I will just note here that there are a couple things we can do to try to prevent some of these side effects. So Mesna can be used to try, and a lot of hydration can be used to try to flush out your bladder so you don't have some of that buildup of the acrolein, which is what leads to some of the bladder toxicity. Also, the other thing to note is it really is a cumulative dose. You can see in some of these comments, it's 50 to 100 grams are what increases the risk. And in a lot of retrospective studies, patients that were treated with Cytoxan for the rheumatic disease, the median dose was only 9 grams. So we are not using so much compared to some of those chemotherapeutic regimens. It always feels scary when someone says, I'm going to be on a cancer drug. And so just in terms of the frame of reference, we are using sort of lower doses overall. What about Rituximab? That was the other one that's a possibility for induction in that patient case, right? So Rituximab was approved to treat malignancies initially. That was in 1997. And then it was approved to treat rheumatoid arthritis in 2006. And then it attained approval for MPA and GPA for induction in 2011 and then maintenance in 2018. Rituximab's also used in lupus, cryoglobulinemia, Henoch-Schönlein, non-systemic vasculitic neuropathy. It works basically by binding to CD20, which is a marker on B cells. And B cells are the cells that are responsible for making antibodies such as ANCA. So it shuts down some of the operation of these B cells. And so the dosing for Rituximab, there's 2 different options for induction, which is that first phase of putting out the fire, either weekly for 4 weeks, or you get one dose and then 2 weeks later, essentially you get your second dose. And that's usually how we try to shut down the fire. In terms of maintenance with Rituximab, there have been a lot of studies that have been done in the last 5-ish years looking at different maintenance regimens. And it will be a little bit tailored based on the severity of your disease and a conversation between you and your provider. But usually we use about 500 milligrams to 1,000, so 1 gram every 4 to 6 months. And there is pretty good data that says, especially in those first 2 years, you really want to have fixed dosing. So you don't want to just get a dose when you feel like crap or when your labs are bad. You want to just sort of regiment it for those first 2 years, get fixed dosing regimens, and then after that, you can talk with the doc about tailored therapy and what your risk for relapses are. Some of the common reactions here are itching, nausea, vomiting, some dizziness, headache. A lot of people feel just kind of cruddy the day after the infusion. That's pretty normal. We do try to limit those side effects by pre-medicating with Tylenol, Benadryl, steroids. And if you do have issues while you're getting the infusion, a lot of the infusion nurses should really know how to sort of slow down the rate, stop it, give you medicine, and turn it up really slowly. It doesn't mean that you necessarily have to stop getting the medication, period. But there can be some severe infusion reactions where people feel like angioedema, like itching in their throat or sense of throat closing or trouble breathing. Usually happens with the first infusion. So if you tolerate that first one, then that's probably at least a good sign. So it's less likely to happen with further infusions. But it still can occur, so you want to be aware of it, and you want to let whoever's doing the infusion know if you're having any of those types of side effects. Some of the other concerning side effects include infections, right? With active vasculitis, you have increased risk of infections, and with these medications, you have increased risk of infections. So as rheumatologists or as any of your medical providers, we're always trying to tease out is what's going on with you, from an infection, and how do we walk that fine line between over-treating and causing too many infections or under-treating and letting the vasculitis be active. So we will be monitoring blood counts regularly. One of the things that we look for is low neutrophils, or like a low specific white blood cell, or low proteins, basically IgA, IgM, these types of proteins in your body that are trying to help fight infection. So those are things that we'll monitor for over time. Really rare is progressive multifocal leukoencephalopathy. If you see that on the list when you get the handout about Rituximab, it will probably freak you out. Legitimately, it is a scary side effect, but it is exceedingly rare, and you can see the information there. And there is no real value to testing for JC virus, which is sort of that predisposing virus for PML, because most people would test positive. Some of the tests that we check before or during treatment with rituximab include a hepatitis and TB panel. There is some risk of reactivation if people have these underlying diseases. So if you do have it, we put you on treatment for that as well. Sometimes we'll be monitoring those B cell counts to see when your B cells start to repopulate when you're on rituximab. Monitoring your blood counts, like I said, the quantitative immunoglobulins. Some docs will choose to monitor ANCA titers. I'm in that camp, but there are two different camps, and so some people will follow those, some people won't. And then you do, with rituximab, as much as possible, if you have the option to get vaccinations before the infusion, you should do that. That's because, like I mentioned, the rituximab is shutting down the B cells, and that's part of what helps you create an antibody response when you get a vaccine. It doesn't mean that you can't have any protection with a vaccine while you're on rituximab, but especially with the more recent studies looking at COVID, ideally, if you have the option, if your disease is stable and you're in remission and you can, it might be worth spacing out your rituximab doses if you really need to get vaccinations. The response is a little better after 9 months as opposed to in those first 6 months. But you can talk with your physician, of course, about the ideal timing for your rituximab and for your vaccines. So other updates, and this isn't a medicine, but when we're thinking about ANCA vasculitis, I mentioned that one of the big themes here, and the person speaking after me, Dr. Villaforte, will be talking about steroids and all of the awful things that go along with them. So I won't get into it, and I'm sure you all are well aware of some of the miserable side effects of steroids. But as a community, we really have been working to figure out ways to use less. So how can we use less but still get the inflammation under control is a question that all of us have been grappling with, patients and researchers and all people providing care for vasculitis. So this trial was looking at really sick patients with severe ANCA vasculitis. So they had kidney involvement or bleeding in the lungs, and they were given their standard induction therapy, so either the rituximab or cyclophosphamide. This trial was primarily looking to see if plasma exchange is helpful in these really severe patients, but an important part of this was looking at the steroid dose. So patients were randomized to either getting plasma exchange or no plasma exchange, but then they were further randomized to either getting standard dose glucocorticoids or a reduced dose. And what that means is standard dose, so usually we're getting down to 5 milligrams of prednisone by like 5-ish months. With the reduced dose, that we were kind of getting you down to 5 milligrams within like 2 to 3 months. So a significantly shorter time of being on steroids. The other thing was in this trial, they cut the dose in half on week 2. So usually if this has been your course, you're on like 60 milligrams for a while, and then you go to 40 or 50, and then you go down and down and down, like just a little bit at a time. In this trial, it was cut in half after the first week. So if you started at 60, week 2, you were on 30. So overall, less cumulative steroid exposure. What they found, not surprisingly, was that the people in the standard or in the reduced dose arm got less steroids. But what they were looking at was mortality and progression to end-stage renal disease, and it was really equal in both groups. So it didn't, you didn't get better control of the disease if you were on the longer dose of steroids or higher doses of steroids. And you had less risk of infections with this reduced dose regimen. So this was actually a pretty big game changer. The reduced dose steroid regimen was as effective for induction and had less infections, and it really informed our guidelines. So the ACR and Vasculitis Foundation released guidelines on the management of across multiple vasculitides. And now in GPA and MPA, we recommend using a reduced dose glucocorticoid regimen over the standard dose regimen. So now we are automatically, based on our guidelines, trying to get people off of steroids sooner. What else is there to try to reduce steroid burden? This is one of the newer medications that has been approved for the treatment of GPA and MPA, Avocopan. It's an oral C5a receptor antagonist. And I won't try to teach you the this entire pathway over here, but basically complements are little proteins in our body that are an important part of our immune system. And there is a pathway by which this C5 binds to a receptor. Avocopan is a medication that blocks that interaction, and when that interaction happens, you have more neutrophils, which are the central part of ANCA, the N in ANCA vasculitis. You have more neutrophils becoming more active, a lot more vascular permeability, so a lot of these inflammatory types of proteins can get out into your blood vessels. So it tries to block that interaction. And the original studies looking at this type of medication in working in ANCA vasculitis was in mouse studies. So what they discovered is if you inject a mouse with this type of, basically with a vial of ANCA vasculitis. If you inject the mouse, it will develop this glomerulonephritis, so it'll develop inflammation in its kidneys. But if you block that interaction some way between C5a and its receptor, and then you inject the mouse, they are protected from developing that. So it started in mice, and then they started studying it in different trials in humans. And the final trial that sort of led to approval of this drug was the Advocate trial that was done in over 300 ANCA-positive patients with new or relapsing disease. And basically what they did was you'd get your regular induction with rituximab or Cytoxan. One group got this medication, and the other group got prednisone. So they was trying to see, can we use a drug that can replace prednisone? And what they found when they compared the two arms was, in terms of remission at week 26, so at 6 months, Avocopan was non-inferior to glucocorticoids, and at 1 year, it was actually superior in terms of maintaining remission. Not surprisingly, the patients who were given Avocopan had less toxicities from steroids because they were given less steroids, and the side effects were about the same in both arms in terms of serious infections. Quality of life was better with the Avocopan drug. So FDA approved it, and it's now approved in Europe as well. So, you know, are we out of the woods with steroids? Not completely. It's not considered a steroid-sparing agent, or it is considered, sorry, a steroid-sparing agent, not a replacement for steroids, because there was some steroids given even in the patients in the Avocopan arm. But it is approved at 30 milligrams twice a day to be used as an adjunctive agent for inducing remission in patients who have relapsing or new disease with ANCA vasculitis. There are still some questions that physicians ask and that patients ask, you know, how do you taper the prednisone? Every doctor will have a little bit of their own style with this because there wasn't one set regimen in the study. Maintenance rituximab, you know, I talked about induction and maintenance. So we have the same maintenance, or we have the same induction regimen, but the patients who were given rituximab didn't get a maintenance dose, and that's kind of our standard of care right now, to give a dose at that 4 to 6 month mark. In my patients, I'm still giving that dose, but that's a little bit not exactly what was studied in the trial. The cost of the drug is always, you know, something that comes up. Steroids are really inexpensive. This drug is more expensive than that. But the cost of, you know, in terms of quality of life and side effects and everything else is also something to consider. The other question that we don't have a complete answer to, but hopefully will, moving forward, is how long to use this for. The trial was done over a year, so we have to figure out, you know, what to do beyond that year. So with this medication, you want to check liver enzymes, you want to check hepatitis B prior to starting, and this is just sort of general information that you'll be told if you're started on the medication. All right, so we talked about rituximab, cyclophosphamide, and Avocopan. I'm going to shift over to, and I know this can feel a little bit like a laundry list. I'm happy to take questions, but it's hard to like talk just about all the medications and make it tailored to each different disease. So I'm trying to hit some of the big ones that a lot of people are on. So we'll talk about azathioprine and methotrexate. Azathioprine was used a lot initially for maintenance in ANCA vasculitis. It was shown to be as effective as Cytoxan. I mentioned all those miserable side effects from Cytoxan. So it was really exciting when azathioprine was used as the main maintenance agent. That was the case until recently. It's been largely replaced by rituximab as the preferred agent for maintenance in ANCA vasculitis. However, if you are on azathioprine and doing well, it doesn't mean that you've got to stop it and switch and start using rituximab maintenance. Both can be effective, but most of the time now we're using rituximab for maintenance. It was used for kidney transplants by the British in the 1960s or earlier. It's also used in inflammatory bowel disease, in lupus, in Takayasu's, in polyarteritis nodosa, so it is used in a lot of our different disease states. I have the mechanism of action here. It basically works on DNA synthesis, and it has a little bit more focus on T cell, suppressing T cell function over B cell function. Some people, if you're on this, they might test an enzyme called TPMT beforehand. That's an enzyme where if you're deficient in it, it can increase the risk of having bone marrow suppression when the medication started. Not everyone checks this across the board, but you know, if it is checked and you're really low, this maybe isn't the right medication for you, or you should be started on a really low dose and make sure they're watching blood cell counts while they titrate up the dose. Common side effects: anorexia, nausea, vomiting, some GI upset, sometimes skin rashes. The main things we're looking out for are bone marrow suppression. So we'll check like I said, your blood counts pretty regularly at the beginning, and then every 3 months. Super rare, but have seen it, is a pancreatitis, and we'll be checking liver enzymes as well. It doesn't progress to cirrhosis, but it can cause some bump in your liver enzymes. And then there are certain medications that if you're on those other medications, your doc should be making sure that they're adjusting the dose of the azathioprine. Methotrexate It's been used in multiple disease states. It's one of our gold standard drugs in rheumatology, including it's been used in malignancy, rheumatoid arthritis, scleroderma, vasculitis. In our diseases, we use much lower doses than those used in malignancy. I know people come in, they're like, oh, it's a cancer drug. It's not. A lot of our drugs are used in different fields, and it really has much more to do with dosing and the way we're giving it, and they're studied in different ways in our diseases. So we use about 7.5 to 25 milligrams weekly. The common toxicities here are GI upset. That's one of the biggest ones for every drug, but nausea, stomach aches, some loose stools. And then some people will have fatigue, headaches, just sort of feeling kind of crappy and flu-like. Occasionally you will always give this medication with folic acid to try to help reverse some of the side effects or prevent some of the oral ulcerations and hair loss and things like that can happen. And I think I have something about it. Yeah, so you can get mouth sores and some hair loss, but you can do 1 milligram of folic acid, and you can actually increase the dose if you need to. So I have some people who are on 3 milligrams a day. There's also leucovorin, which is sort of a heavy-duty type of folic acid that can help with some of the side effects. So if you are having intolerance, a lot of times at the beginning you'll feel kind of just like your stomach feels gross and you don't feel good. A lot of people do get used to it over time, so if you can tolerate it, I would say at least try to stay on it for couple weeks, and sometimes your body builds a little bit of a tolerance to it, and then you can eventually titrate the dose and try to make some adjustments to keep on the medicine. For this medication, we are following liver enzymes, blood counts, so we're regularly going to have blood work at least every 3 months, looking at your liver enzymes, looking at your blood counts. You want to avoid heavy alcohol use. It is processed through the liver. Some is fine, but it's something that, again, your doc will be looking at your liver enzymes, and you don't want to binge drink really much on this drug. Other than that, the other main thing that we want to make sure in this medication is that if you are a female of childbearing age, it is fetal toxic. So you really do not want to become pregnant on this drug. So that's something that we always want to counsel our patients on if they need to be on it and are of childbearing age, to use multiple types of protection. All right. So now I'm going to switch disease states, and we'll talk about a different case. 75-year-old female with 3 weeks of new onset right-sided headache, malaise, shoulder and hip girdle, so this whole area, discomfort, 12-pound weight loss over the past 2 months, morning stiffness lasting about 2 to 3 hours. She has difficulty getting out of a chair and combing her hair from the pain. She had some onset of jaw pain when she was eating, had a transient episode of vision loss in the right eye, but it resolved after a few minutes. She comes in to see you. You're either going to get a temporal artery biopsy or a temporal artery ultrasound if your center has that, or if you live in Europe, which you probably don't if you're here right now, other than you. And so inflammatory markers, and then basically based on all of that, the presentation and the workup, you believe that she has giant cell arteritis. So in these cases, we do consider IV steroids if there is threatened vision loss. So occasionally we will actually have someone come into the hospital and get IV steroids, but a lot of times we'll just treat with high-dose steroids if you don't have that vision loss symptom. So it's usually 1 milligram per kilogram per day. So that's your standard regimen to start. This person does have long-standing diabetes, and we know all of the side effects of long-term high-dose steroids, and so you'd like to start Tocilizumab. So what is Tocilizumab? It is a monoclonal antibody. That's what the MAB stands for. Whenever you're seeing all these words, MAB at the end means monoclonal antibody. So it works by inhibiting the effects of a protein called interleukin-6. It was initially approved for rheumatoid arthritis in the US in 2010, and then it was approved for GCA as a subcutaneous weekly injection in 2017. And more recently, it has been approved as an IV formulation, which is really nice. And I know around the pandemic, it was also being studied in COVID, and so there was a lot of access issues with Tocilizumab. So now having both injectable and infusion options is kind of a nice win for our patients. So like I said, what it does is it blocks IL-6 binding to its receptor, and IL-6 is responsible for a lot of different symptoms. So it can increase like your fevers, and you can see some of the different things that IL-6 is responsible for here: bone resorption, matrix degradation, tissue degradation. It's basically very inflammatory, and this helps to shut it down and shut down that interaction. It was studied in a large trial called the GIACTA trial, and what they looked at was weekly injections of Tocilizumab for one group of patients. The other group got every other week dosing, and then they compared it to what the standard of care was, which is a really long steroid course over about a year, or a really fast steroid taper. So those were the 4 different arms of the trial. And they were looking at, obviously, the ability to get people into remission, and then also how much steroids we could get you off of and how quickly we could reduce the steroids. What it showed was that Tocilizumab was effective. It was able to get people into remission. You can see the weekly Tocilizumab in terms of sustained remission at week 52. It was 56% of patients, and then the numbers were significantly lower for prednisone only. A lot of patients in those prednisone arms had more relapses, so it was more effective than what we had been using up until that point. And patients felt better. So their patient-reported outcomes, when you're filling out all those forms with a bunch of questions about how you're doing, those measures were better in patients who were on Tocilizumab. So this is used in giant cell arteritis. It's also used in some cases in Takayasus that's refractory. Usually first line from our guidelines is to use a TNF inhibitor, but in other cases we might use something like Tocilizumab in Takayasus. There are still questions about this medication that patients ask me a lot, right? So how long should I use this, and like when can I stop it? Which is the question that makes sense. Everyone wants to know when they can stop all these medicines, right? And I can tell you it's not that easy to study those questions, right? Because we're cautious people. Even when we're aggressive, we're cautious. We don't want this disease to flare up. And so studying the best and safest ways to come off the medicines can be tough. But in this trial, it was a 1-year trial. And I'll just say that when patients stopped the medication after a year, about half of them after 1 year had relapses. So that's good and bad. We didn't have good signals, like in terms of clues that would let you know that this is the type of person that's going to have a flare when we stop the medicine. That would be great if we had a biomarker or some way to say this is what we can check, and you're in that group that's not going to flare, so we can stop it at 1 year. We don't have anything like that. There was no clear signs. So the good news, though, is for even the patients who did flare after stopping the medication, pretty much all of them were able to re-get disease control once they were restarted on Tocilizumab or a combination of Tocilizumab and steroids. So we can rein it back in, but I prefer to do more of a tapering process where I'll give the weekly dose for at least that year, maybe a year and a half, and then I start tapering it and spacing out the doses of Tocilizumab. Again, all physicians will do it a little bit differently, and there are different ways to approach it, but I kind of try to space it a little bit at a time and just keep on weaning it till I have them on like an injection every almost like few months, and then I feel like I'm treating myself more than the patient, and then I'll stop the drug. So that's kind of my approach, but again, everyone will do it a little bit differently, but this was a huge win for management in GCA. Some of the precautions are diverticulitis, if you have a history of diverticulitis, not diverticulosis, which is just like big holes kind of like or like bigger, I don't know even how to describe diverticulosis, but diverticulitis is inflammation of these pockets in your colon. So if you have had that, you would know it. You usually are hospitalized for it. You're usually on IV antibiotics. That's something that is risky with this medication because it can increase your risk of GI perforation. Again, any vaccines you can get to protect yourself, I recommend doing so. In terms of herpes zoster, so the shingles vaccines, all of those types of vaccines that you can get, all of these medications, many of them can put you at increased risk of getting viruses or having reactivation of viruses. We will monitor your cholesterol while you're on this medication because it can increase your cholesterol numbers. It's not really recommended for those with bad liver disease, and we also do watch your neutrophil counts as well to see whether we need to maybe decrease the dose. Monitoring-wise, we'll look for signs and symptoms of infection, screen for TB. Like I said, with a lot of these medications, you're going to need pretty regular lab screening, which is going to happen regardless because we're looking for signs of vasculitis, and we're also looking for signs of medication toxicity. So these are just some of the things that we look for with Tocilizumab. And then I will wrap up here with Mepolizumab. So what is Mepolizumab? IL-5, it blocks IL-5. Again, it's a monoclonal antibody. So IL-5 is a protein that regulates the growth, the activation, and the survival of eosinophils. Eosinophils are really critical in driving some of the inflammation and damage in EGPA. And higher levels in you see higher levels of IL-5 in patients who have EGPA, and it's associated with disease activity. So initially, this drug was used in severe eosinophilic asthma, and it was approved for relapsing or refractory EGPA in 2017. So you can see the normal signaling on the left, IL-5 binds to its little receptor on the eosinophil, and then you get more propagation and activity of the eosinophils. And these are some of the medications that are out that sort of basically try to block that interaction. The only one right now that's approved for EGPA is Mepolizumab or Nucala that's on this slide. The other two are being studied. So how is this approved? Mepolizumab was studied, and again, I know I was just sitting in the EGPA session there. A lot of the data that we use in the treatment of eGPA is kind of extrapolated from our GPA and MPA patients because we have more of them. They are different disease processes, but this is one of the few trials that really specifically looked at eGPA patients. So it had 136 relapsing or refractory eGPA patients. Basically, they were either given this drug every 4 weeks, plus their standard of care, or they were given placebo. And then they were followed for a year. So what they were looking at in this trial was accrued remission. So how many weeks out of that year were you in remission? The percentage of people that were able to get remission, what was the relapse rate, and then what was the steroid dose. What they found was that there was more accrued remission and people achieving remission on Mepolizumab. There was a lower relapse rate, and in terms of steroid dose, prednisone less than 4 milligrams a day by the end of this trial you were able to get prednisone to less than 4 milligrams a day in the Mepolizumab arm, half of the time almost, versus only 7% in placebo. So it did have a significant steroid-sparing effect as well. Some of the side effects, patients will sometimes complain of headaches, injection site reactions, some arthralgias or fatigue. It works really well in some of the respiratory or upper respiratory types of symptoms, rhinosinusitis, the things that we think about as associated with eosinophils, which is what it's targeting. So it works also especially well in people who have baseline elevated eosinophil counts. So that is something that we usually try to make sure is happening before we can even get approval for the drug. Other medicines that are being looked at that block IL-5 include Rituximab and Mepolizumab. So hopefully in the next bunch of years, we'll even have more options to offer our patients. So these are some of the medicines that I wanted to just go over because I think hopefully they apply to a couple different disease states. I'm just showing the different side effects from the medications that we use in vasculitis. There's bone marrow suppression, there's rashes, there's oral ulcers, there's kidney dysfunction, liver dysfunction, hair loss, lung lesions. I mean, there's a lot of different things, and we have increased risk of infections. And this same exact slide is the same as signs of vasculitis. So just highlighting that it can be very difficult to differentiate between not only disease activity and damage, which we try to do our best to do, but a lot of times we'll be trying to figure out, do you have an infection or do you have a side effect from your medication, or is this from your vasculitis? And so, you guys know your bodies better than anyone and better than we do. So you're going to have to be able to, pay attention to how you feel, make sure you're communicating with your doctors, but it can be difficult to tease some of these things out. So where are we going? Side effects of medication can have significant overlap with the disease manifestations, and that can make management of these diseases difficult and complicated. But with an increased understanding of sort of what is driving these different diseases, we've been able to develop new drugs that are more targeted, and we have many more that are in the pipeline, which is also very exciting. This helps us to minimize some of the risks and the toxicities, but it does come at a cost. With these newer drugs, we don't have as much data, right, on long-term toxicities. So they are newer drugs, and we're, they have been approved if we're using them, but we don't have the long-term information that we have on some of the longer-standing agents. Pricing is a challenge, so we do spend some time fighting here, at least with insurance companies, to try to get access. Many current trials are evaluating how fast, and I know that is a question that everyone asks, but again, how fast and we can safely stop or minimize some of these medications. And we're also really doing, I think the biggest change has been figuring out ways to use lower dose glucocorticoid regimens. So we're being able to put people into remission, but we have significantly decreased the amount of steroid exposure overall. And I think we're still looking very hard into that question and finding, where can we draw the line and how can we just really minimize steroids and really find more targeted treatments. Again, with all of these medicines in terms of dosing, and when to make a switch or when to escalate or when not to escalate, you got to talk with your physician about risk factors for relapse, for comorbidities. It's going to be different for each individual, different for different disease states, and it would be all over the place if I tried to talk about those specifics in this talk. But I am happy to answer questions. The more we learn about our enemy, the more we can get more targeted weapons. That's the target part. And less side effects. Our patients will be happy, we'll be happy, and we won't be causing that problem. So that's my talk. I will take any, oh yeah, I guess we have, do we have, did people do that, or you just, whatever you want to do? Here.
I handwriting is hard, but I typed it.
That's fine.
Well, you can just say it, how about that? Sure,
Oh, that's so loud. I also have a primary immunodeficiency, and so there's super hesitation. Are there any any meds that don't increase risk of infection?
Of infections?
Because I have Behçet's.
Yeah. That's tough. I mean, like I said, the activity of vasculitis, when the people have active vasculitis, they're at increased risk of infections. When people are on medications for vasculitis, they're at increased risk of infection. So it's a double-edged sword that way. And in fact, like within the first year of diagnosis, most of the deaths that are happening from infections and not the vasculitis itself. So infectious risk is a real major difficulty. I would say if there are infections that are happening a lot, then sometimes I'll have some folks on sort of chronic prophylaxis for things like, so if you're on more than 20 of prednisone, or if you're getting induced with Cytoxan or Rituxan, we'll put you on PJP prophylaxis. So there are things that we try to do to minimize infectious risk, or even if you get recurrent UTIs, then there are certain medicines you can take kind of long-term to prevent that from becoming active. But because by definition we're trying to sort of shut down the immune system or parts of the immune system in as targeted a way as possible, all of them potentially have an increased risk of infection by the fact that you're manipulating your immune system.
There are better options.
Yeah.
Okay, thank you.
Yeah, of course.
So I have a few questions here from the papers. So a first one about the difference between side effects of drugs and active disease. So the example is mouth sores that could be explained by EGPA, for example, or by side effects of the drugs. So can you help us discriminate between?
It can be tough. So you know, with Methotrexate, that's one of our biggest culprits for oral ulcerations, and sometimes you can get nasal ulcerations with a lot of our diseases. Sores in the mouth and in the nasal cavity can also be there. Sometimes visually looking can give you a little bit of a clue, but I can tell you, I can look at two things side by side, and there's not like one characteristic feature that will 100% tell you. One other piece is really looking is, are there any other signs of disease activity, right? So is this just happening in isolation? Whereas if it's a side effect from a medication, it's probably the rest of your disease isn't necessarily active. In rare cases, like if somebody's having major issues, I might do like a really short course of low-dose prednisone to see if it completely goes away. If it's active disease, it's probably going to solve it. If it's the medication, it's not going to solve it. There are little ways to try to test whether it's from the medicine itself or from your disease. But one of the biggest clues, I think, is looking at the other signs of disease activity to see if that's happening. Other options would be to hold the medication that you think is causing it for a few weeks if you're in a position to be able to do that. So if your disease is overall well controlled and you happen to have oral ulcers, hold the medicine. Don't do it on yourself. Talk with your doctor because you don't want your disease to flare. But you know, you could hold the medication for a period of time to see if that goes away, and then re-challenge and see, is it really from the medication or is it not? That'd be probably how I'd approach it.
Thank you very much. A question about Avocopan. So it's been developed as an induction therapy. So it's steroid sparing for the first months of treatment. Are there any room for its use as maintenance therapy?
Yeah, good question. In the trial, it was studied as an adjunctive agent for induction, right? And so we are using it along with Rituximab or Cyclophosphamide to try to get people into remission. I still continue the medication for that year because that's how it was studied, and that was what showed at 52 weeks that there was less relapses. So I think it's reasonable to use it in maintenance in that sense, just as it continued from your induction. But in somebody who's has the disease, just sort of adding on the medication, it just hasn't been studied that way, so I'm not doing it that way. So I don't know. There could be in terms of when you're thinking about the mechanism, but I wouldn't use it just randomly as an add-on agent until we have more trials or data looking at that type of situation.
And maybe one last question. Are there any new drugs currently being tested for vasculitis that you are excited about?
That I'm excited about? Yeah, no, there really are a lot, and I mean, you're welcome to talk to this too. I feel like there has been a lot of research looking at specific pathways, and so I mentioned some of the ones like IL-6, IL-5, like the Tocilizumab, the Mepolizumab. You know, we borrow from our other colleagues as well, so there are a couple in the pipeline that have been used in, say, like allergic asthma, like I mentioned for EGPA, that are being studied in EGPA. There are a couple of novel types of treatments. There are JAK inhibitors, which are used in rheumatoid arthritis, that are being studied in some of our vasculitides. They're kind of related to IL-6, but not specific. It's easier if I had a picture to explain how they work. But those have worked really well in rheumatoid arthritis and in some of the other more common diseases like ankylosing spondylitis, psoriatic arthritis. So they may have a role, and those are oral agents actually. There's a slew of them, honestly. There's a lot of different medications that are really in the pipeline. Again, some of them repurposed from other fields, some of them newer agents that are being specifically developed. There's other complement inhibitors. I mean, it would be a long list, honestly, but I'm excited about all of them, honestly, because even if they don't work, it means we're moving closer to understanding what's going on. So I think anything that we're able to sort of get more information on and study is a win for the vasculitis community. Yeah.
Maybe one last question is.
Hi. I just wanted you, if you could clarify the Avocopan for me. I'm on right now the 5 milligrams of prednisone down from 60, Remicade and Imuran. I cannot wait to get off the prednisone. Is there a way, like, I know it said not to substitute the prednisone, but I mean, isn't that kind of what it's for?
Well, no. I mean, I'd like to say yes, but it's not. It's not a substitute in that sense, because it hasn't been studied to look at, like, can you just, throw on, like, sprinkle on a little of that medication versus, how we sometimes bump up the prednisone. It's really specifically studied in ANCA vasculitis, so that's one piece. So I wouldn't just extrapolate from that to like other disease states until it's studied. Yeah, until it's studied in other disease states. And I don't think of it as an agent that can get my person from like 5 to off. It really wasn't looked at that way. I wish it was, but that's not what it was studied as. And so I think to use that would be a misuse of trying that drug.
So
Yeah.
it's not even applicable to my disease yet?
Yeah, no. But we'll see where, and once the molecules look, like I said, we borrow from lupus, we borrow from rheumatoid arthritis, and there's a lot of sharing that goes on with different immune agents, so we'll see what else it's, studied in, but at this point, no, it's approved in MPA and GPA during induction.
Thank you so much for your great talk.